sometimes there's a bit of a delay. Either way, it's entirely inappropriate. And so only the referrer should be able to downgrade an urgent suspected cancer referral. So if in your practice or your patch you are coming across anything like this, it's worth raising service alerts for, and I'd also encourage you to just let me know the details so I can also take it up internally. Even if you're noticing that you are having rejections for patients who may want to see female clinicians, or if they can't make it at a certain time, they shouldn't be rejected, and to send more work to the GPs to do. So it's just to make sure that we're working, our colleagues all across the board are working in the same way to make sure we're not really doubling up on workload, and just to make sure it's all the same across the board. Does anyone have any thoughts or questions or anything about that?
So Chet, Tammy, oh, it's Tammy. Tammy, come in.
Thanks, Hannah.
Sorry, I can't.
Yeah, no, you might be able to see the chat. It's really helpful if you could involve us as LMC as well. There've been lots of sort of pilots that have been going up to maybe to some CDs, and it doesn't seem like anyone knows what's happening, and so it'd be helpful to kind of have a little bit more of a strategy about how we're going to kind of manage all of the requests, but also to keep sight of kind of what the learning is, and so there's some decent outputs. And then my other point was around the fact that if there are issues, that we do have an interface meeting that Rima, myself and others go to, so it's also useful to let us know, so that if you can't go to that meeting, that we can also bring that up at an interface meeting. But thank you, and welcome. It's great to have someone in post.
Super, great. Yeah, it'd be nice to meet you guys, Tammy, as well at some point. So at least we can sort of establish a nice little point of contact. And yeah, I think we'll take that offline, and I'll email you. Super. I'm just looking for any more hands. I don't think I can see any.
There's no hands. There's a comment from Dr. Sheetal. Sheetal, do you want to share that example quickly now?
Oh, hi, Chetak. It's Sheetal. I'm a GP partner at Sangam Surgery. So yeah, we had a locum doctor who'd seen a patient, a middle-aged gentleman who was a smoker, and he had both throat pain for a year and dysphagia, and the locum doctor sent him on a 2-week upper GI referral, which was rejected. I think the only suggestion they said was GP can request an urgent endoscopy. We did, in fact, refer him to head and neck in the end, but yeah, it was just a straightforward rejection with really not much to offer. So that's where we get stuck as well, because then the patients come back to us saying, why has the referral been rejected? Yeah,
absolutely. What would be good is to investigate exactly what happened here, what department did what, and in what time frame, and whether things were done according to guidelines and stuff. If you would be able to email that to me, I'd more than happily investigate it, and then we can sort of take it forward.
Okay, thanks, Chet. Can you put your email in the box in the chat? Thanks.
Yeah, so I just propped up my cameras, so I can't see the chat, but let me put it up.
He's not going to check his email anymore.
Thanks, Chet. Rima's got her hand up. Rima.
Hi, Rima.
Hi, Chetak. Just to follow on from Sheetal's point, so I think there have been examples of this happening, and we've had sort of conversations with particularly Barts, because I think they've been downgrading some of these referrals or rejecting. So I know, Chetak, you're probably involved in some of those conversations that happen with your equivalents in Waltham Forest and Newham, and especially that link with the Cancer Alliance as well. So yeah, really helpful if anyone are having these examples, then it's good that we feed it back, because there is that sort of cancer safety quality team sitting within Barts that need to be made aware of these. I think it's happening in some particular specialities, but it's not for them to downgrade a referral without a full justification. And if a GP feels that it needs to be a 2-week wait, then that should be, it should still be valid. So, but I know, Chata, you're in that sort of, you have all this connection, so that's great. Thanks.
Yeah, that's absolutely right. The GP has to agree to downgrade the referral. It shouldn't get rejected just outright. So please, any issues like the one Sheetal has raised, please email me, and I'd more than happily help in any way I can. Thank you all.
Chet, hold on, before you go, I've got one question for you.
Yeah.
So if I as a GP do a 2-week wait referral, hospital may deem it to not be appropriate. So they might say that it needs to be a routine referral. What I've noticed is the way that it's communicated back to the practice is not consistent. So it might be that we've got our safety netting systems in place where we might see the patient or ring the patient within 2 weeks to check they've got the appointment. It's only when they say, oh, I didn't get anything. If we then go on to Cerner, we might see that they've got an appointment, in another 6 weeks or 2 months or whatever. Or if you go on to the ERS system, then you can see that there's been some sort of change to the referral. So I think what my feedback would be is that could we have a clinical document or something like a letter sent so that it's integrated into the EMIS system, so we're not having to look on other systems, because we're not made aware. And we might have not hyped up, but we would have prepared the patient that, I'm suspecting cancer, you're going to be seen in 2 weeks, make sure you're available at short notice. And then they might get a letter saying that they're going to be seen in 6 weeks or 8 weeks or whatever. So I think from my side, I would appreciate if there's some sort of system where we're notified a bit more consistently.
I agree. You can't really have a system where you're having to chase 4 or 5 different places to see if you've had a letter or an appointment or anything. That's not appropriate, and that shouldn't really be the way that referrals are changed or downgraded at all. So there does need to be a uniform way, whether it's a document or an email address that is manned. Something like that needs to be uniform across the board. I absolutely agree.
Thanks. And Nadine.
Hi, Chair. Also, just a question. Sometimes there are 2-week kind of NICE criteria, but the local criteria don't always match. So you can't do a 2-week referral, although NICE is telling you. Like an example is above 60 anemia, refer for lower GI, but we're not allowed to on our cancer referral forms. So is there a reason why there's a discrepancy often between national guidelines and what we do locally or London-wide?
I mean, the thing with the 2-week wait cancer guidelines is there are criteria which would allow you to refer without question. But there is also an element where if you as a GP still have suspicions for cancer, you can still raise a referral, and it should still be addressed. And if the hospital has any feedback for that, that should be addressed back to you directly. If they wanted to downgrade or change a referral, there can always be discrepancies, and we're working to try and make them as the same all across the board. But if you have suspicions for cancer for a patient, you shouldn't. I wouldn't want just a few strict guidelines to stop you from advocating for that patient. And again, if there are any issues here, feel free to contact me offline, and we can discuss whether if there have been any issues with it. But situations like that, someone anemic over 60 with a negative fit test shouldn't stop them from still being investigated.
But it's not allowed on the 2-week form for lower GI, so they've got kind of fit and a mass, and that's their criteria. So I'm saying there's a discrepancy between the national guidelines, which we're supposed to follow, and the BART's forms. I don't know if they're London-wide. Anyway, I'll email you, Chet. Thanks.
Yeah, email me. I'm pretty sure I thought on the form there's a section where even if they don't meet the criteria, you can still refer.
Yeah, you can. No, you are right. They often reject them or downgrade them.
They shouldn't get rejected or downgraded. That's where the issue is. Okay. And if there are rejections there, at that point, I'd really like to know.
Thanks.
No worries. But yeah, please email me if there's any specific concerns as well.
So Reema's just pointed out that, that it should be the pan-London forms, which are all consistent. We do have access to other forms on our system. So if we could just all make sure that we're using the correct form. And Reema's also added there's no Newham specific cancer guidelines. So those forms should be consistent with the NICE guidance then. Okay, good. Thanks, Chair. It's been really good to have you join us. And I think that you know that we mentioned, or somebody mentioned, that it's been a while since we've had a cancer lead. And I think I'd just like to take a second to just say that our previous cancer lead was a very passionate man. We sadly lost him, but I think he'd be really happy to see somebody that's just as enthusiastic and looking forward to working with us all. So thanks for joining us, and thanks for speaking to us today.
Thank you all. Really looking forward to working with you guys.
Thanks, Chair. Okay,
Thanks.
So we've got Dr. Rahana, who's going to be talking to us about the high intensity users and admission avoidance.
Hey everyone. Thanks Alpna for having me on the call today. So for those of you that don't know me, I'm Rahana. I'm a GP at Claremont Clinic. I'm also the clinical lead for Frailty for the borough, and more recently the plan care lead also. This piece of work is a collaboration between the Urgent Care Working Group, the Frailty Working Group, and also the Federation. So it's a really nice piece of work that we're doing with all GP practice. So we just wanted to talk to you a little bit about what the project is and what the action so far and what the successes so far have been. Maggie, if I could have next slide. So how does it work? So GP practices are asked to share their high intensity user SNS search list for the last quarter. And then depending on the age, if they're under 65, we'll work with them via care coordinator to make an admission avoidance plan where necessary. Sometimes it is like they've gone appropriately to A&E. Other times it's they weren't really sure where to go, so they've pitched up in A&E instead. If they're over 65, they get a little bit more. They get a comprehensive geriatric screen and get pulled forward for a geriatric review. Then also, if appropriate, they'll get an urgent care plan review, which we'll update as part of the service as well. More complicated cases come to the MDT, which a lot of you have already been attending. As you know, the MDT has two parts: one where we bring cases, and two where you guys get to then bring up your queries, and then we kind of capture other services in that. So our searches are limited to the search from the hospital. So we only pick up whoever's attending A&E. The cases you bring might be one-on-one callers, people that are accessing mental health crises like numerous times, or other community services are also being impacted by high frequency attenders. So through the MDT, we are getting a 360 review of everyone that might be attending with overusing services. Can I get the next slide, please, Maggie? So the service went live on 6th of January, so not too long ago. We've been live for about 10 weeks now, and we've got 37 of our practices participating. Of the 3 MDTs, we've already held 2, and the last one will be on the last Thursday of this month. And I just want to thank everyone for attending, because the participation and the attendance for those meetings has been phenomenal. And we're kind of getting really good care plans and ideas that we haven't really thought of before as well, and we're really moving conversations forward. In total, we've managed to review 548 patients. 341 have accepted our support, and then we've just kind of listed all the current onward referrals that we've done as a result of those patient contacts. Because some people were unreachable, we've also extended the service to now include some evenings and also Saturdays as well, to make sure that we're catering for all people. Next slide, please, Maggie. So what's our learning been so far? The common themes are patient expectation. So I won't say that GP appointments are not available. Sometimes it's just that it wasn't in the time frame that they thought it should be available in. So they might have been expected they should come in to see a GP on the same day, but you've offered something within the next 1 week. So I think there's a bit of work to do around there. Also, lack of awareness that they could have gone to pharmacy first, or an alternative place other than A&E. Or rightly so, a GP seen them, assessed them, and then they've sent them off to A&E. Homelessness is also a big thing as well. So where they haven't got no fixed abode, they're pitching up in A&E, and it's a little bit hard to discharge them. And then also complex cases all that require specialist input, but they're not being able to reach the secondary care teams. So they're also just being diverted back to A&E as well. So far, the major service gaps that we've identified, which we feel might be easily fixable, is catheter care. But I'm kind of going into a little bit more detail on the next slide of that. And then also the direct access to secondary care teams for people with known long-term conditions already under the specialities. So in terms of actions, next slide with Maggie. We've done a lot of work on patient education and accessing services. So as part of the service, everyone gets an admission avoidance plan, and that kind of says, you've highlighted, these are your issues, this is what we've done with you. And at the bottom, we're also developing a patient information leaflet that's got new and specific services on there as well that they will be given as part of their admission avoidance plan. And that will be going out to everyone that's had a patient contact with us as well. For our failed encounters, we're also doing something similar, where we'll also give them a little leaflet on accessing services other than A&E as well. So that's a work in progress. Through the MDT, I think one of the cases highlighted was the 4th frequent highest caller to 111 in the whole of the UK. So we've managed to have proactive conversations with 111 and the practice involved. And that person is now on a kind of a weaning plan from 111. And last I checked, I think they've only called once in the last couple of weeks. But I'll find out a little bit more when I go back into office next week to see if that's still the case. But it hasn't it had an impact having these conversations. Through the Frailty work, we're also establishing links with the Frailty front door, virtual pathways, and seeing how we can get all of those things opened up with direct access to primary care as well. With the catheter care, the ELF service doesn't have a consultant. So even though the district nurses and the continence nurses identifying that actually we need to flush things faster or we need catheter changes faster, they can't do that unless they've got a consultant say so. So I think we're kind of seeing if we can get them that support, and Rima's been really kind to link me in with the right people for that to happen. Equally, where the hospital told us they've got patient-initiated follow-up pathways, we're just kind of following up on that with to make sure that actually those are still active and live, and which ones are there for which specialities. And hopefully we might be able to get some comms out to you guys as well to say, actually, these are the live ones, like these are all your IBD patients should go down this pathway instead. And that might just provide a little bit more guidance for both the patients and for yourselves as well. And through the work, this is slightly unintentional, but CGL have really come on board with working with primary care, and I think they've been reaching out to all the PCNs now to share their dashboards and actually look at the throughput that they're getting, what they're doing, who are their frequent flyers, and how actively they're able to engage those people as well. So I think it's a really nice collaborative piece, and lots of different parties through just interest have come through and really contributed to this piece of work. But yeah, that's all I kind of wanted to share with you guys.
Thank you, Rohana. That was really insightful. Do we have any questions? No questions. Right, so Parul has shared the date for the next meeting, which is Thursday, the 27th of March, from 1 to 3. Do we have any? Oh, Karen?
Just to say, although obviously some of the decisions coming out of NHS England and ICBs yesterday may change things, at the moment there is consideration at the ICB to continue this project. So they haven't confirmed and they haven't absolutely said, but they are keenly looking at it with a positive view. So we do hope that they will continue to resource the activity. And as you can see, Rohana and Parul and the team have managed to get some really good learning already and some really good results. So we're hoping that we'll be able to keep the project going forward.
Thanks, Karen. Do we have any other questions or comments for Dr. Rohana? No, so thanks, Rohana, for today, and we'll see you at the next meeting then. Okay, thanks. Right, so the next item on our agenda is our Q&A session with Dr. Rima. So I think Rima's got some updates for us, and then if we've got any questions for her, we can ask them. Rima?
Okay, thanks, Arpana. And just wanted to say, firstly, thank you to the clinical leads for presenting today. I know Chetak, especially because obviously you're new in the role, but it's been really, really helpful. I think it's just good to kind of share what some of the clinical leads are up to, because sometimes it can be so detached. So thank you to the both of them. So a few updates from me. Obviously, Karen's already kind of alluded to it. So yesterday kind of all blew up, yesterday in terms of the announcement around the 50% reduction in NHS England, kind of broadcasted by the Labour government. We didn't know, but obviously they announced it's going to also be extended into the ICB. So this came as quite an unexpected kind of shock to us all yesterday. We still don't know what the implications of that's going to be. They're saying it's 50% on kind of reduction of like running costs and programs, and we don't know the impact of what it will have on our clinical leads. Obviously, all our clinical leads across North East London, majority of them are all funded by the ICB. So there is some uncertainty about how that's going to look. They're expecting some of these changes to happen fairly quickly, so by October. So obviously, it's a difficult position that we're all in, but I will obviously continue to fight our corner for clinical leadership in Newham. So I just wanted to just make sure that everyone's sort of aware of following the announcement sort of yesterday. So an update on community with midwifery prescriptions. So I think I gave a quick update last time on the GP forum. So some of the practices have already given, almost all practices have given notice around seizing prescription requests from the midwifery team. Some practices have already started that. So I think their start date was in the beginning of March. Other practices have given an end date for the end of March. We had another meeting on Wednesday with the team over at NUH. So they've put a new SOP in place, which seems to be working okay. So they've got an SHO who's basically doing all the prescriptions. This also is including the community midwifery as well. So they've been trialing it out. They still are not sharing the SOP yet because it needs to be signed off internally. Now, one of the questions that we raised is for those practices that have already switched off, if they're still receiving these requests, then who do they contact? They have said to reply back to whoever who has sent that request. Can practices please respond back to that email address to say that we are not doing the prescription as per the new SOP that's in place. They will then pick that up, and they've got an internal process. If that person's on leave or etc., that email will get picked up. Okay, so even for those practices, once you switch off on March 31st, if you're still getting requests, then please just respond directly back to that email to say you're not basically doing it. I'll open up obviously to questions. Actually, I might just stop there. There was another point around the communication back to practices as well. So like if a pregnant lady has a positive MSU that needs antibiotics, if that's communicated back to GP, we would want that communication to say, well, the antibiotics have been prescribed. Now they're looking to put that communication onto the electronic patient record, but obviously for IT reasons, they're just trying to work through how they're going to do that. From my point of view, they don't need to notify us if a patient has got an abnormal MSU if they have acted on it. It's only if there's something particular that they need to communicate. So it can, for us, I think it's fine for it to go on the electronic record as per, other patients who have investigations done within BARTS and is followed up by the team in secondary care. At that, I'm just going to stop at that point because are there any questions around that specifically before I move on?
So Rima, I've got one question, and then Tammy can go after me. We all, or many of us have sent that letter saying that we're giving you 3 months' notice. There was a letter that was circulated after the PM forum that is sort of a template. Are we all using what? I just wanted to get an idea of what everybody's doing when they're rejecting that work back. Is everybody sending that template letter that was circulated? And I think it's the LMC letter that was circulated by Mina or on behalf of Mina. So are we
I don't know anything
encouraging
about that.
everybody? I'll forward you the letter, but I think it is an LMC template, but and I think we're ticking boxes to say,
Okay.
so is that what everybody would be advised, or is that what's recommended, that we all reply back, please see
I
attached
didn't know
letter?
that, but if there is a template there, then yes, use the template, but it needs the response needs to go back to the person who has sent that email request for the medication.
Okay, I'll forward
Yeah.
you that letter. And then the other thing that we can perhaps do is, I know it's been shared, perhaps we can share it a bit more widely so that everybody has it, and we can ask CEG to put it onto our resource publisher as well, so then it's accessible to everybody.
That's fine.
Tammy?
Yes, please do use the letter. I think that's a really easy way of us sort of monitoring what's happening, and it's just an easy tick box. And I did share it with Mina to send out to all of the practice managers. So sorry, Rima, if that didn't hit you, but we've been using it for quite a while now. So that would be really helpful. And then also it's saved into the patient records, and you can give the patient a copy of it as well as if you want to. So those things are really important. My question about the maternity was just to say, well done everyone. I think it's a really positive step, and it just goes to show what we can do collectively. And absolutely, we do not want notification if results have been actioned. So Rima, that's definitely something there. I just think moving forward, it's just about making sure that the patients are also aware, so that they're not pitching up to us if they're not sure about results. So I think we just need about our comms, so some patient-facing comms about changes of procedure once that's in place. But with everything, we do need holding statements. So it'd be quite nice to get to all the practices, all the who don't get to come to these meetings, just so that they are aware that this is the new process. Because I think there are going to be some that have fallen through the gaps who may, like yourself, not know about this letter. So if there could be some formal sort of ICB comms about this is the change. I think there's one thing us saying it as LMC, it's in our newsletter, but actually it needs to be accepted by the system, and this is the new pathway. I think there just needs to be a little bit of we're working on it, just an update for those who don't necessarily come to this meeting. Thanks.
Yeah, thanks, Tammy. On that, I do think the communication should come from BARTs though themselves, because this is actually their own decision. I know we've pressed it, but it's actually their own SOP that they've put in place. So we're waiting for them to finalise everything, and then we can do the actual comms. I don't want to get anything wrong in an interim comms, and if they change their mind with anything. So once it's all fully formalised, then I will ask them to draft the comms. They are having their conversations with their patients continuously anyway, so they are telling them that obviously you will not get your prescription from your GP anymore. There will be that you'll be issued here. You will need to come to the hospital pharmacy to collect it. Yeah, but I will get back to them around that sort of comms piece as well. Yeah. Okay. I had another couple of updates. So one of them's around the same day access. So I think there were a number of PCN meetings yesterday that have happened. I think majority of PCNs have now sort of given in their preferences of how they want to do the arrangements for the SDA. So if there are any PCNs yet still to, please can you get in contact with the ICB primary care team to let them know. That's one. The other one has been around our secondary care interface meeting. So we had one about a few weeks ago. Again, sort of quite positive in terms of direction of travel for those 4 domains that I've spoken about before. So fit notes, even though they're not quite on the electronics that part, to process with the electronic, they're still providing paper copies to most of all the departments. Again, if you're getting any patients that are coming to you for fit notes for those that you've had either procedures or inpatient stays, can you please let me know, or let LMC know, however you want to do it, but can you please raise it, because that's the only way we're going to know if it's not working, and that's the only way we can feed back to secondary care. A letter was sent to all the consultants from the chief exec at BARTS reminding them about consultant to referrals, and also reminded them to make sure that their information that they're giving on outpatient letters and discharge letters is clear action points, and those that have already been done and not for the GPs to do. So that's been done more as a comms out to all the consultants. Again, if you're seeing some of these letters, can you please just raise it, because we have to keep consistently putting that pressure on. And then that's it. Yeah, that's it from my updates.
Thanks so much, Rima. And we've got Hina with a question.
A question. So we are recently getting letters for procedures done at hospitals, and patients are coming to us to do provide the wound care. So they are coming to the practices with practically no letter, nothing. Yesterday itself we got a patient who came in who had a procedure. Go to your GP and they will carry on with the, the necessary. Nothing is in the letter. It's an open heart surgery. So this is happening quite a lot recently. So Rima, would you be able to take that back? And I'm not the only practice. I have these conversations with other practice managers, and they are having similar issues where patients are walking into the practice with wound, expecting us to provide the wound care. I do understand that we can turn the number away and we can, go, but some people are really elderly people, and it's like going back from one service from another service. It's quite difficult as practice to turn them away every time.
Okay, Hina, you mentioned it's cardiology. Have you had any experience with any other surgical departments?
Yes, we have extra from gastroenterology. We have got this as well. I can give you a few examples within my own practice.
If you don't mind, please,
Yeah.
can you email them to me so I can forward them on?
Yeah.
I guess it's just I'm trying to understand, is it past the 7-day follow-up, or we need to just be clear as to whether that is actual practice nurse wound dressing work or not. So yeah, I'll need to look into the cases.
The letter was simply, patient had, I saw that letter yesterday because my nurse was very confused. So the letter says the patient had an open heart surgery, needs suture removals. That's it. And you can see he had a major surgery and they have been sent to the practice. If I open the wound and if I find something, what do I do with it? Do I just close him and tell him, get away, go wherever? So I did advise my nurse, we're not going to touch this because you don't know what you'll find. The patient needs to go back to where he had the surgery or go to A&E.
Okay. Thank you, Hina, for raising that. I'll take that back.
Thanks.
Wax?
Yeah, Reams, I just wanted to say, been in various conversations around what happened yesterday. I've looked back at most of the footage and read most of the reports and letters. There's nothing in there to say that there should be any threat to clinical leads. And I've read that multiple times and I've heard that multiple times. I think our position for the ICB from a Newham perspective, other boroughs can take the same perspective or their own perspective, should clearly be that we need to move away from this ICB culture of culling clinical leads when the hand is tight. It's not acceptable. We all have regular meetings with each other. We're pretty transparent about the work that we do. In fact, I would go as far as to say we would want some transparency from those making such decisions around the work that is done and what is done to look after X contract and what is not done to look after X contract. It's very easy to qualify a clinical lead's time. You look after so many patients, you do so many blood pressures, you do so many HbA1cs, you do so many health checks, you do have impact. These are evidence-based incomes. It then really does say, this is from a clinical lead perspective, not a quango kind of situation. NHS England will lose their clinical leads. That means we will only have clinical leads locally. And we absolutely know the triumph of patient, clinical lead, and manager, how that works and how impactful that has always been. I would probably not accept anything that the ICB says around clinical leads going more than re-recruit to when contracts are coming to an end. This knee-jerk kind of add clinical leads into the pot, it should not. That's not what West Streeting or Keir Starmer said yesterday. It was all about the Quango. By all means, from the NHS England perspective, it's going to be abolished over the next months to a couple of years. Okay, we have to deal with that. But we can't, politicians can't make decisions for patients, especially clinical decisions. And we're best placed to do that. So I think the message needs to go back strongly. I've said it to Jay and Mark, that the clinical leads are here to stay, and we won't be accepting any change in that, because absolutely what we have left, the bones of what we have left, and look what the comments that we've had around Chet coming, and Philip in the past, that Arpana said as well, and it's great. And Rahana's been here today. We did some Q&A around primary care last week, etc. We can't lose all of that, because that's the one thing that builds trust with patients. And then when I say trust, there's a report out by the Health Observatory last week that absolutely contradicts what our PSQs and MSFs say about us as doctors, that there's literally no trust with primary care and doctors. We need to build back trust. Losing clinical leads will not solve that situation. So anything that we all can do to push back around assumptions that are being made and the expectations that clinical leads for the scrap heap, we need to stick together on that one.
Thanks, Wax. Do we have any other questions or comments for Rima? Rima, can you just remind us of the date of the next interface meeting so that we can try and get any examples into you before then?
Yeah, it's not going to be till about May, June time. So we haven't got a date fixed as such, but it's be around that time. So we've got enough.
All right, so I think if just a reminder to everybody that send your examples to Rima so that she's got she's got a bit more substance when she's taking these things back to that meeting especially.
And me too, please.
Oh, sorry, and LMC too. To be fair, I think that you can send the same email to both of you. Yeah. Okay. Thank you. Thanks, Rima. Okay, so we've got Raylene here, who's going to be talking to us about the spring COVID vaccination program. I know that I'm not sure about everybody else, but my patients are, the desire to take their COVID vaccine has been dwindling down. So I'm really keen to hear from you, Raylene, to see how we can get patients to be a bit more enthusiastic about getting vaccinated. So Raylene, are you online?
Hi, yes, good afternoon. Yes, I am online. Luckily, I thought I'll just dial in a little bit earlier. For those who don't know me, I'm Raylene Fernandez, and I am the program manager for the NL-ICB, the IMS and vaccinations team, and also the borough lead for Newham, Tower Hamlets and Waltham Forest. So the reason why I'm here today is just to quickly run through the upcoming spring 2025 campaign, and I can see Vax and Nakul on the call, which is really helpful. If you could, whoever is presenting could go on to the next slide. So just a snapshot for those of you who've not seen this already. So the campaign starts on the 1st of April. And with a priority to older adults in care homes and eligible housebound patients, and it will end on the 17th of June. In terms of cohorts, so we have adults aged 75 and over, residents in care homes for older adults, and individuals aged 6 months and over who are immunosuppressed. So quite a small cohort in compared to the autumn-winter campaign. Next slide, please. I just have 2 slides. It's really brief. So in terms of the summary, so across NEL, we have around 230 sites, which is almost double to what we've had in previous campaigns. So we've got good coverage in terms of, and this includes community pharmacies, PCNs. So we are currently onboarding sites. So we're doing a lot of webinars. For some of you may have attended our first webinar yesterday. So and SBOC is presently just supporting sites who have not signed agreements. So any other queries with relation to their stock, etc. And so first allocation of stock has been completed for PCNs. And also for the other for pharmacies, and as I said, training for all sites in preparation for the spring 25 campaign. And for Newham, we have around 40 of community pharmacies, so in terms of the spread for the community, and around 14 care homes. Yeah, so that is just some initial information. And as I said, we're still onboarding, we're still supporting sites in preparation for the kickoff on the 1st of April. So that's just a quick summary of the spring campaign. And so I did mention, I know you mentioned that the hesitancy with communities in terms of the uptake, and we don't have data, unfortunately, in terms of, so I couldn't bring any data from the autumn winter, but that is something which we've experienced. That is one of the topics which comes up in practically every meeting, that the hesitancy, and Vax is here as an outreach, so he's been providing outreach, and that is one of the goals as well of the comms and engagement we've had in with our communities in terms of addressing, having those conversations to address vaccine hesitancy. Any questions about the spring campaign or anything else?
Any questions? Wax?
Yeah, I was going to say, so we actually presented the Newham work at the King's Fund on Friday, and it was really, really well received. It was off the back of the report from the Health Observatory. We've got massive issues in Newham around patients trusting services, whether it's food from food banks to surgery to GP practice to benefits office. We've got massive issues. I've raised this with our public health team yesterday, and actually Northeast London's a bit of a focus, and Newham's a bit of a focus on because our patient surveys are probably the most reflective of that negative position, to the point where patients are on that part of the spectrum where you know, that say that most things are racist policies, and you know what, to be honest, I probably wouldn't disagree for the most part. So we've got a lot of work to do. Newham really had pretty low uptake compared to the other boroughs last phase, and that's not for the want of trying. Essex Lodge went at it, Wood Grange went at it, NHC went at it, the pharmacies went at it, but pretty much it was 1 in 5, 1 in 6 people would accept the vaccine. So we've got more work to do. In the close season, we've been doing more work. The challenge we have is that there is the old classical item of service challenge, the £7.54, I think it is, Karen, or £10 that there is for a COVID jab, and even for a housebound, it's very difficult to do in that kind of funding. So it's a massive loss. The additional challenge we have for this phase is that I've run out of money for text. I can't really afford to send another £90,000 worth of text, guys. I'm really sorry. I know that really works with AccuBook for specifically the over 75s. So I think we've, as providers, we've said that it will be MBS, and walking kind of pages that patients can use, and they know that our doors are open. There's no funding for outreach, so where we've tried to get to underserved in the last phase with over 90 different events, there's no funding for that kind of situation. So there's a lot against us for this phase, and we've been planning for that. So NHC and Woodgrange will reach out to the practices around the housebound, and we'll make a really concerted effort to call those patients at least 3 or 4 times in the 10 weeks we have to get those vaccination done. The care home visits mostly arranged between Market Street, NHC and Woodgrange, so that's pretty much covered. The fixed sites people will walk into based on the back of the MBS, and I think ourselves and NHC will come together to try and do something around outreach and try and tie it into other initiatives that we have and other events that we have or might be putting on. Where we really need your help, is the permission to come to your practices and then call patients for vaccination. Even if it's a flipping broom cupboard, it really doesn't matter. We're pretty self-sufficient. I've bugged Tammy and Nadeem and Femi and Kola so much, and Sharon so much, and we've been at Star Lane multiple times. We've been at Sangam. Anil's been doing some vaccinating. We've all tried, all hands to the pump. Pontoon, Albert, you name it, we've tried it. So what we really do, I know it's really difficult with space, but we'll do it at odd times if you want us to do it as well, where you've got that little 2x2 free and stuff like that. But that is going to be really crucial in this phase, especially off the back of what patients are saying around trust. So I mean, that's all I wanted to say. Our aim is to at least catch up to the other boroughs and get close to the nil average, if not surpass that. But we will need your support in terms of premises to be able to do that. I'm not asking anybody to send texts. Just simply, if you could put our posters up, isn't it, Karen, and leaflets out and stuff like that. We'll circulate all of that. There's of no cost to yourselves. But what we could do with is a couple of hours of some 2x2 space wherever it is in your practices to be able to get to where we need to be with the vaccination. And it's not just vaccination we offer. We offer health and wellbeing conversations. We'll do your blood pressures. We'll do whatever you need us to do for your cough. Let the teams know, and we'll try and support you all with that as well. So that's all I wanted to say. Happy to take any questions, Raleen, if there's anything that I've missed. Oh, by the way, the fourth challenge is it is a Moderna vaccine. We know that's not the colour that our patients in Newham like, but it is what it is, and it's about that journey that we have of building trust with patients. And then the last thing was that a bit negative about COVID, but the flu, well done to everybody. Absolutely fantastic. We've surpassed what we did in most of the cohorts last year, despite lots of challenges around state, weather, finances, hesitancy, you name it. No texts, no self-book, etc. So really well done to you all. And you've but the numbers that we've given, I worked it out as probably saved 37 deaths from flu, and at least around 300 admissions. So pat on the back for everybody there, and that really is the kind of things that we want to see. Thank you.
Thanks, Wax. Manuel's asking, will you be sending digital media info?
Any which way you want.
Good. I think if you're able to do that, then we can put that onto our screens or our websites.
Sure.
So
No
that'll be
problem.
good. And then
No problem.
Karen's just reminding that NHC is working with the practices and the PCNs and NACL and WACS to help with the housebound patients. So please do reach out if you need any assistance with that. Okay, good. Thanks, Marlene, and thanks, WACS. The next item on the agenda is Sophie. So Sophia Sharp, Sophia is our PCN cancer facilitator who's going to be talking to us about early cancer diagnosis. And Sophia, I know we're a bit early, but I can see that you're online.
Hi, hi everyone.
Thank you.
So my name is Sophia, and I am the PCN cancer facilitator for Newham. It's my first time meeting some of you, but I have met a few of you guys before. Thank you to Maggie for allowing me to present today. I'm sure you guys are already aware of the PCN cancer facilitator service, but I just thought I wanted to introduce myself, and as I've come into the role following Jessica Luzzi, so it's nice to meet you guys. If we move on to the next slide. I just wanted to remind everybody of the offer available in regards to the PCN Cancer Facilitator Service. We can collate audit data and develop action plans, facilitate quality improvement and cancer screening improvement, work with staff from clinician to admin level, provide training on screening and cancer-related processes, as well as work with PCNs to support a reduction in health inequalities. If I have met with some PCNs and practices in the call today, but if you would like to meet to discuss any of the above and see what the service can do to help, feel free to get in touch and I'll put my email in the chat after my presentation. If we move on to the next slide, I'm just going to provide some support updates as well as a brief overview of some screening data as Maggie has kindly asked me to show. So this is just in regards to the new initiative being run by NELCA around cancer diagnosis audits, where they'll be asking practices to run the KEG cancer diagnosis audit tool for Q1 and Q2 of 2024 to 2025. And this is with an incentive of £25 per patient being paid to practices who successfully complete the audit. The aim is to support reflection, learning and quality improvement, as well as sharing best practice and strengthening local cancer intelligence. There should have been some comms going out and there is a full service spec as well, but if you'd like more information on this initiative, you can either put myself or you can get in contact with NELCA for more information. If we move on to the next slide, so Maggie has asked me to share some screening data for the borough overall. So this is just a very brief overview, a snapshot view of Newham's screening data, and this is March data, and it's pulled from the KEG dashboard, which everybody should have access to. And this just gives us a picture of how Newham is doing in all three of the national screening programs. The national targets for breast and cervical screening are 80%, and bowel is 60% currently. Newham is falling slightly behind the NEL average for breast screening and the younger bowel screening cohort, but we have noticed a NELCA-wide issue in regards to breast screening coding, which means that the number that is here is probably not reflective of the actual breast screening rate overall. In terms of the DES outlines that actions to improve screening uptake should include auditing non-responders for all three cancer programs and working with the NHS England. Obviously, it doesn't exist anymore, but we'll see what changes there. To work with them to identify and action improvement priorities, as well as adopting an every contact counts approach and making use of resources available to identify local initiatives. I am able to collate this data as well as ethnicity data as well at PCN and practice level. So if you would like a more in-depth look at your PCN's data, then do get in contact with me and I'll be able to create a sort of personalized data pack for your specific PCN and see where we can help with improving these numbers. If we now move on to the next slide, I'm just going to move on to some quick support updates in regards to breast and bowel screening. As I mentioned earlier, we did notice low breast screening numbers across NEL, and this was due to coding discrepancies from coding the manual results. So we have created a breast screening SOP, which is the aim is to standardize the coding process across NEL for breast screening, as well as streamline the processes for admin staff. The SOP is available on the NELCO website, and there is a webinar that we did as well with KEG, and that is available on the NEL Training Hub website, which is linked in the presentation. So yeah, that's a really great resource for admin staff at the practice who are coding breast screening, and hopefully that should bring those numbers up. And then in terms of bowel screening, there is a great resource with Lena, who's based at Homerton, who's the bowel screening health promotion specialist. She will be able to come to individual PCNs and practices and come up with improvement plans, events, and she will help to bring up bowel screening numbers. She's an amazing resource in North East London if you wanted to do some targeted work around bowel. So if you wanted to do that, please get in contact with her, who's in the presentation there, and I'll pop her email in the chat as well. And then finally, if we move on to the next slide, in the last meeting, I think my colleague Yasmin was here introducing the Community Links cervical screening telephone intervention program, and this is for Bangladeshi and Romanian communities, and this is commissioned by Newham Public Health. This is designed to reduce health inequalities and improve early detection of cervical cancer within these communities. And she has asked me to mention that the invites for this program are due to come out in the next few weeks. So if you could please look out for those invitations. You'll have to sign the DPA on the DCC, and then Community Links will run the searches on EMIS and do all of the hard work for practices. So yeah, please look out for this initiative. And if you'd like more information on this Bangladeshi and Romanian cervical screening project, you can contact either myself or Nazma Ali, who is the project officer at Community Links for this project. So that was my very quick sort of overview of some data, screening updates, etc. If you'd like me to meet individually with PCNs and practices, then please pop me an email and I'll be more than happy to meet you guys. Thank you for listening.
Thank you so much, Sophia. That was really useful, and I think it was good to hear from you and getting the reminder about the program that's going to be coming out, because I think that will be useful with regards to the Romanian and Bangladeshi patients. There's a question from Manuel who's asking, can the screening data sent electronically to practices to reduce errors in coding? I think what he means is that, you know, the breast cancer screening.
Yeah.
We get bowel cancer screening
electronically,
and it's coded. It's linked with a code automatically. Is there any scope for that happening in the near future?
So we have fed back to the breast screening hub, and at the minute there is no scope for electronic results for breast screening. It would include a general overhaul of the whole system at the breast screening hub, and they've come back to us and said they have no scope for it right now. So whilst it would be really, really helpful for everybody if they could, it would save everybody a lot of time. But no, I'm afraid at the minute we've been met with no from them. So I'm sorry about that.
Tammy?
So I just think you need to take that back, Sophia, though, because we cannot, as general practice, constantly be picking up. So this is one bit of coding that we need to do. There's so many other, sort of really important bits of coding, and I've written down so much coding for practices to do, and that's why there will be errors. So moving forward with any new programs, we have to let the IT help us with some of this. So really, it's not. They're saying they haven't got the capacity to do it. Neither have we.
Exactly.
So it does need to be thought of. Thanks.
100%, and we do keep in regular contact with the hub, and we do feedback every single time. But yeah, hopefully in the future, you know, funding may change and they may decide to change the way they do things at the hub. But the answer that we've been given by them for now is in the foreseeable future, no. But I do hear you.
Sophia, can I just add to that? So I think it would be good if you're able to feed that back. But alongside that, unless I'm incorrect, my understanding is that when a patient is due for breast cancer screening, they get a letter inviting them to book the appointment, as opposed to getting a letter saying this is your appointment date and time. So what we have is we have a lot of patients where we get a DNA letter, but the patient says that, but the letter said to call when I was ready to book for it. So do you see? I think there's a difference in the way that previously, so when I first started working in Newham, we used to get an email that would have it was an Excel spreadsheet that had the list of the women that were due for screening that year.
Yeah.
And for our practice, so we were
Yeah.
able to opportunistically remind patients that your breast cancer screening is due on, it's due now. Make sure you go, or when you get we don't get any lists or anything like that. So
Yeah.
And we have so much call recall to do, so that's not
Yeah.
part of our daily routine.
Exactly. Yeah.
But I think that that might be a reason why there's a lot of non-attendance for breast cancer screening. It's the wording on the letter.
Yeah, definitely. And this is something that, the Cancer Facilitator Service is here to do. So if you have any problems with the hub, we can provide that sort of connection and feed it back to the hub and give them that sort of feedback. So yeah, I'll definitely take it back.
And then one other thing is that for cervical screening and for bowel cancer screening, there's a text message that's sent out. I don't know if a text message is sent out for breast cancer screening.
No, a text message is only sent out after they've actually booked their appointment, so they won't get anything prior to them having an appointment.
So I think for the cervical cancer screening, they'll get a message to say that your screening is due, please book your appointment.
Yeah.
And for bowel cancer screening, that you're such and such age, you'll
Yeah.
be sent your bowel cancers. So if we could look to see if
Yeah.
there's any scope for having a text message sent out for breast cancer screening.
Yeah, definitely.
Thank you, Sophia.
Thank
Does
you.
anybody have any other questions or comments for Sophia? No? Okay, thanks for joining us. And I think that if I can just remind practices that please do reach out and contact Sophia if you wish her to attend any PCN meetings or practice meetings or for any other support. Yeah. Okay, good. So we finished a little bit earlier today, which I think is great. Does anybody have any questions, comments, any other AOB that they wish to bring to the meeting? No? Okay, good. I think just a reminder, SNS invoices quarter 1, 2, and 3, they're due to be sent today for those that haven't sent it. Wax?
I was just going to say what you just said, sorry.
Okay. I in my head I was like, it's because I haven't done it. So I will be doing that at some point today. Anything else that Wax or Rima, Nadeem?
No, all good for me.
Tammy?
Can I just switch hats and go to diabetes, please? So the type 2 diabetes in the young, on your templates for your 26 to 39-year-olds, you will see that extended diabetes appointment. If you haven't ticked that box, so you've done the work, please go back and do that coding so that you will get your payment. Thank you.
Thanks, Tammy. So we've got 2 more weeks till the end of our year, but then we can relax a little bit before it all starts again. So I hope everybody's okay, doing okay. For those of you that are celebrating Holi, happy Holi to everybody, and happy Ramadan and happy Eid Mubarak to everybody that's been observing Ramadan as well. So I hope everybody's keeping well. Take care, and we'll see you at the next meeting. Okay, bye.
Thanks.
Bye all, thanks.
Thanks, everyone. Thanks, Abra.
Thank you.
Thanks, Abna.
Well chaired again, Arpana.